Boa noite a todos. Em nome do Colégio Brasileiro de Cirurgiões, quero agradecer o nosso convite de participar aqui desse webinar, onde também represento aqui o Comitê de Cirurgia Robótica, também deste colégio, e mediante a isso nós vamos ter o prazer e a satisfação de ter aqui uma apresentação do professor João Martinie, que atua como cirurgião hepato-bilio-pancreático na Carolina do Norte, e é um parceiro de longa data aqui já do Brasil, que sempre ajuda, uma experiência enorme em cirurgia hepato-bilio-pancreática por via minimamente invasiva, especialmente pela robótica. E nós teremos como debatedor desta apresentação alguém que tem uma experiência enorme, conhecido por todos nós, professor Antônio Kalil, uma satisfação apresentá-lo. Sou Antônio Kalil, professor da Universidade Santa Casa de Porto Alegre, e é diretor da Santa Casa de Porto Alegre também. É uma satisfação, uma honra muito grande tê-lo dois aqui conosco, tá, nesse webinar, para a gente poder debater e conversar um pouquinho sobre perspectivas em cirurgias robóticas e também sobre desfechos da cirurgia bilio-pancreática. Obrigado, professor Kalil, por aceitar o convite, participar conosco. Thank you so much, John, for your participation. We appreciate it.
Happy to be here.
Prazer grande também. Agradeço aí ao Raphael e a todo o colégio, ao Van Baten e a todo o grupo aí pela oportunidade de participar e de aprender com o John aí essa noite.
Ok. Acho que agora a gente pode seguir para a apresentação.
Hello, my name is John Martinie. Hello, my name is John Martinie, and I'd like to thank the organizing committee for the invitation to speak to you today. I'm going to speak about robotic HPV procedures and an update on surgical outcomes. I'm currently at Carolinas Medical Center, Atrium Health, which is in Charlotte, North Carolina, in the United States. I do have disclosures, most notably, I do a fair amount of teaching and work for Intuitive Surgical, in addition to some of the other surgical supply companies. The introduction, I would like to discuss the growth of robotic HPV procedures and outcomes, focusing on three major procedures in our practice, including robotic distal pancreatectomy, robotic pancreaticoduodenectomy, and major hepatectomy. We'll briefly discuss and present some oncologic outcomes in addition to surgical outcomes. This is certainly not meant to be a technical talk or how I do it talk, so there will be minimal video in this presentation. I think it's important to remember the surgical outcomes that we see in the literature oftentimes are presented and published in a surgeon's learning curve. And we know that early outcomes are often inferior to our traditional approaches, either open or laparoscopic. Longer operative times, less efficient, sometimes higher conversion rates than traditional laparoscopy, higher complication rates overall compared to open, oftentimes, including mortality. And sometimes the expected benefit of the robotic platform is not always manifest in the outcomes. Sometimes I believe there's perception that there's little benefit to these new methods. Certainly, I would say that's the sentiment amongst many HPV surgeons in the United States. And this frustration leads to abandonment. So certainly there's many surgeons who tried robotics, decided that the benefit wasn't there, then we essentially stopped doing them. I think it's important to remember this. Any possible long-term benefit for patients undergoing a robotic surgery for pancreatic cancer, either a Whipple or distal pancreatectomy, any benefit is easily negated by sloppy techniques and inferior short-term outcomes. So that if you're learning to do robotic Whipple procedure and your outcomes are poor, you have lots of fistulas, lots of takebacks, reoperations, bleeding, that will negate any benefit to your patient from a cancer standpoint. I think that's important to know. Now, when I started robotics in 2006, I thought the robots were a very fascinating technology, but the initial robot itself was a very bulky system. I personally looked at the robot as a $1 million needle driver. And I really saw benefit only for select cases. There was no benefit, in my opinion, early on to easy cases such as a cholecystectomy, because we could do those laparoscopically already. And the thought of doing a Whipple, seemingly at the time in 2006, was really incomprehensible. So I started in my career, early cases, by doing completion or reoperative cholecystectomies, hepatocogyginostomies, distal pancreatectomy, probably the most important operation early on for me, and other niche operations, gastric and duodenal resections. During that time, over the past 17 years of doing distal pancreatectomies, we've certainly evolved from doing open to laparoscopic and hand assist to robotic. The operation itself evolved from standard operations where we would perform a lateral to medial approach and then to doing more radical operations. Splenic preservation also evolved from initially doing a Warshaw procedure to vessel preservation procedure, which is a longer, more challenging operation. During that time, we developed skills on the robot and proficiency, which helped us overall to expand the cases that we do. 2006, again, a first generation robot, and we led to efficiencies. And just to demonstrate, some of the things that we did at the time, which was essentially mobilization of the pancreas and using laparoscopic instruments, because there were no robotic staplers at the time, and there were no vessel sealer at the time. So this is our first generation or first version of doing a robotic pancreatectomy. And at this time, we would staple the pancreas with the blood vessels intact oftentimes. And this would be what I would consider a version 1.0, very primitive technique. The limitations at the time, again, we had limited instrumentations. We had no staplers, no vessel sealer. The ergonomics were not ideal. And it was this time we were learning our skills and learning haptics and how to avoid conversions and how to avoid complications. All of this was demonstrated in our early learning curve. So this is the first paper that I ever published on robotics, was in 2013 on our initial series of 77 HPV procedures. And in this, including about 40 distal pancreatectomies, you could see that our operative times were just slightly over our laparoscopy time, but we did have the benefit of reduced blood loss and length of stay. Now, of course, this is not randomized data, so you have to understand that we were very selective early on with our robotic cases, but over time, we expanded our criteria. Over time, we ultimately came to do all of our pancreas resections robotically, at least my practice, and we completely abandoned laparoscopy. We abandoned doing a Warshaw procedure. We started doing more vessel preservation, distal pancreatectomy. And for cancer, we began doing a much more radical distal pancreatectomy. So that is a more extended resection with a more extended lymphadenectomy. At this, we also were able to eliminate the conversions because we learned the tricks of the operation. We learned how to avoid bleeding and how to getting out of trouble. A good example of this is a vessel preserving distal pancreatectomy, trying to preserve the splenic artery and the splenic vein. And this is suturing a small hole in the splenic vein with a 6-0 polypropylene suture with a tiny needle. And so this is how we got better with time. Our skills got better. Something that happened inadvertently because we started doing more complex distal pancreatectomies and more intricate operations was that our operative times actually never got better. Because of that, we started doing more of the complex cases. The other reason for this rather flat line on the OR times was that as I got better as a robotic surgeon, I began allowing my residents and my fellows to do more of the operation, which again affects your OR times. But with time and with evolution, we began to make the operation much more like an open operation. This is a patient with a pancreatic adenocarcinoma located in the tail, invading the stomach wall. This patient was treated with 3 months of FOLFIRINOX neoadjuvant chemotherapy. And you can see this still invading the back wall of the stomach. This is doing what I think is the more radical part of the operation, which is doing the celiac lymphadenectomy. You can see here taking out lymph nodes in the area. This is actually station 8 lymph node, which is the common hepatic artery lymph node. And you can see the robot has excellent visualization so that we can see this is the common hepatic artery. And this is how we do a distal pancreatectomy for adenocarcinoma now. So it's a very different operation that I was doing in 2006 or 2008 or 2012. We've gotten a lot better at doing this operation. This is how we do it nowadays at our institution. When you look at the outcomes because of that, and we looked at a subgroup of patients who underwent a laparoscopic versus robotic distal pancreatectomy who were having procedures for cancer. And we look at this and we see that overall the operative times are still a little bit longer than laparoscopy. And I would argue that's because we do a little bit more intricate operation. Sorry. In fact, splenic preservation was more than 3 times, maybe 4 times better in the robotic arm than in the laparoscopy arm. Furthermore, we've essentially eliminated the use of hand ports, and the conversions to open is also lower. And so that's how we see the outcomes. If you look at the fistula rates, these are about the same. The mortality and other complications are all about equivalent in laparoscopy versus robotic. Now, what about the oncologic outcomes? We can see here, this is comparing patients with cancer. Again, this is a propensity matched study. And you can see here that our lymph node yield in the robotic arm is almost double the laparoscopic arm. Length of stay is about the same. And then if you look at R0 resection, again, seemingly slightly higher in the robotic arm, although it did not reach significance. And the median overall survival is probably 50% higher than the laparoscopy, although again, it didn't reach significance due to the underpowering of the study. So overall, the message is that most series show comparable short-term outcomes for both laparoscopy and robotic distal pancreatectomy. The robot definitely will allow you to do more complex and radical operations. And there's a tremendous benefit to having surgeons advance through their learning curve on this operation. What about Whipple procedure? So Whipple procedure, it's a long, complex operation. There's a long learning curve. There's a high morbidity and mortality. And I think a surgeon considering doing robotic Whipple really needs to have mastered doing this operation first. Some of the early data, this is a paper from University of Pittsburgh, which is probably the leading center in the world for robotic Whipple procedures. This was their early data, though. This is their first 50 robotic Whipples, and you could see they had a fair amount of morbidity still, comparable to open. They had 1 mortality, and fistula rates was about 22%. If you look, however, at their operative time was fairly significant, almost 9 hours, with a fair amount of conversions, and length of stay was 10 days. So I think when this paper was published, 2012, and came out, many surgeons were not convinced that robotic Whipple was ready for prime time. Fast forward another 10 years, and this is a randomized study from Netherlands, which showed, which compared open with the minimally invasive Whipple procedure. And this study actually was terminated early due to the mortality, the unexpectedly high mortality in the lap and robotic arm. And so the cautionary note from this is that when you start doing these operations, you really need to understand they have a high mortality. People really need to be careful when they're starting to adopt this procedure. This is our operative robotic experience at Carolinas Medical Center in Charlotte. I can tell you that I did 6 years of robotics before I did my first robotic Whipple. And I think that's important to know. We've never had an operative mortality. You need to be very careful and gain your experience in robotics very carefully. That allows you to evolve your technique to get better at suturing, better at controlling blood vessels, better at eliminating complications. And it evolves over time to where we're at now. And the way that we do this operation now is almost identical to the way that we do open Whipples. These are all pylorus preserving Whipples, the pancreatic anastomosis, the biliary anastomosis, and the duodenal anastomosis are identical to the way we do these open. So it's not a compromise in technique from the way we do things open. When we do a robotic pancreatic anastomosis, again, this is identical in almost every way to an open procedure. And I think that's important because the outcomes, the operative outcomes for a Whipple are in large driven by the anastomoses. That is, if you have fistulas, if you don't have fistulas. So it's really important to be absolutely as good as possible during the reconstruction phase. This is doing the pancreatic duct with small 6-0 monofilament absorbable sutures. And this has to be done with absolute perfection, in my opinion. The same thing goes for the bile duct anastomosis. This is a hepatocogygenostomy on a small duct. This has to be done perfectly with interrupted monofilament sutures. This can't just simply be done with one of the running barbed sutures, because you're going to get strictures, you're going to get leaks, and you're going to have problems, and that will affect your outcomes. It's very, very important. When we look at our outcomes, because of that, I think in large part because of how we took on robotic Whipples gradually and built our career, built our experience, when we look at patients who undergo a robotic Whipple and we compare them in a propensity match study, single institution, if you look at this, these are all patients who underwent a Whipple for cancer. If you look at the operative times, they're slightly longer in the robotic arms, but all other complications are lower, including blood loss, length of stay, and readmissions. So also, somewhat to our surprise, certainly my partners, was that our lymph node yield was almost double in the robotic arm compared to the open arm. And if you look at all other complications, which we cluster together in something called the Comprehensive Complication Index, or the CCI, looking at blood loss, bleeding, delayed gastric emptying, ileus, urinary retention, fistulas, wound infections, the overall CCI is lower in the robotic arm than the open arm. And that allows you, if you have good outcomes, good perioperative outcomes, that will lead to this. It will lead or may lead to improved long-term outcomes. That is the improvement in median overall survival and increased length or time to recurrence. Now, both of these, this is one of the only studies in the world that's ever shown improved oncologic outcomes for a robotic Whipple procedure in a propensity match study. Now, these don't reach significance because of the underpowering of the study, but I believe that with a proper studying, with the proper powering, that we would demonstrate, in fact, that these are real benefits. Another good review article, which I would recommend, is a paper by Melissa Hoag in Journal of Surgical Oncology, which is, I won't have time to summarize, but essentially outcomes for robotic Whipple are heavily dependent on the surgeon and hospital volume and experience. And they're in evolution. So I think in the next 10 years or so, we're going to see continued validation that robots allow reduced blood loss, lower length of stay compared to open. I think that we'll find that the postoperative pancreatic fistulas are going to probably settle out somewhere in the range of open technique that is under 10%. And then I think that there are several studies now which show that there's increased lymph node yield in R0 resection for robotic versus open. I suspect it'll take another 10 years or so to have good randomized data to validate this, however. Now, I'm going to switch gears for the next 10 minutes. I'll talk about liver procedures. My initial perceptions for the robot was that, hey, you know, it's really not that useful. I need to, when I'm doing a laparoscopic liver resection, I need to have staplers, I need to have energy devices. And at the time in 2006, there really weren't those instruments for the robot. I also, in my mind, you know, I thought, well, I need to have a hand port in and I need to have a big extraction port. So it doesn't make any sense to have a robot. So I've, in my own mind, had kind of talked myself out of doing robotic liver resections. And so when I started doing laparoscopic liver resections in 2006, a lot of these were done with hand ports and extraction sites and things like that. But over time, over the 17 years of doing robotics, at some point in that time, after 6 or 7 or 8 years, I finally switched from doing laparoscopic to robotic liver resections. What that allowed me to do was essentially eliminate the use of endovascular staplers, eliminate the need for additional laparoscopic energy devices, and to eliminate the need for a second surgeon at the bedside. So these are all now one surgeon operations. So we could say goodbye to something like this. When I started robotic liver resection, I initially started specifically for the hilar dissection, and I felt the weak part of the operation was the parenchymal dissection. But as the tools get better, as we got better technology, better instruments, things like that, that limitation actually went away. Allowed me to do much more complex operations. And so with the evolution of the technique, we got better at the techniques, we got learn the tricks, we learned the robot, the choreography of the procedure. And so all of this evolved over time. So the initial surgeries that we started doing with the robot, you can see here, is doing the hilar dissection, where we're dissecting out the right hepatic artery, which is certainly doable with laparoscopic skills. The right artery is often extrahepatic and accessible to divide. And this is 2012, probably 10 years ago. But what's harder to do laparoscopically without a robot is to get around the right portal vein in the hilum, or even the left hepatic vein, or do other very intricate dissections. And so this is, to me, a huge advantage, was just to do this inflow dissection for liver, and really allowed me to take that next step over into fully MIS. Now, the initial operation, we were limited in the instruments, as I mentioned earlier. This was the harmonic scalpel, which was attached to the robot, but we were still using laparoscopic staplers. So at this point, this was 2012, this was having a second surgeon at the bedside, and that's how we did this 2012. By 2014, this instrument came out on the market. This essentially allowed me to eliminate the need for the harmonic scalpel and to use less staplers. And so this was how the technology evolved over time. I think there's a lot of literature out there now, but the first real paper that came out talking about robotic major hepatectomy was from Giulianotti, describing their outcomes. And this was a single surgeon study, retrospective, demonstrated 24 fully robotic right hepatectomies. So that is the gold standard today, in my opinion. Operative times, excellent. operative times 337 minutes with a blood loss under 500 cc's and 0 mortality. So this is a great paper as the reference. It took us 6 years or so to accumulate enough patients for this paper. This was our study from our center, which was comparing laparoscopic and robotic liver resections. Over a 5-year period, we performed almost 500 major liver resections. 173 were done in a minimally invasive fashion, and that was broken into robotic and lap. And these were all major hepatectomies, right hepatectomies and left hepatectomies. And you can see here a comparative overall demographic. Patients are fairly similar in terms of the indications for surgery and the pathology. But you can see here in the robot arms, we had a not significant, but there's a trend towards a lower blood loss. And actually, this is the only paper in the world which shows actually a lower operative time for robotic versus laparoscopy. I want you to remember that because we'll get back to that in a minute. The operative time. Why was our operative time faster? It's mainly because we were very experienced when we started doing these operations. So we were no longer in our learning curve. That's very important. When you look at the other complications, overall complications, lower in the robotic arm, lower readmission rates, lower length of stay, and overall ICU stays are significantly lower. Now, this is perhaps the best paper out there now, which is a systematic review. Ruben Syria is the lead author on this paper, and this looked at all of the literature and robotic and laparoscopic liver resections in a comparative study, and you can see the growth here. Now, I want to highlight a couple things. So they reviewed almost 3,000 cases with 150 manuscripts. They were primarily focused on comparative studies, either robotic versus lap or robotic versus open. And we'll go through some of this in detail because I think it's really important to look at this paper. Now, if you look at overall complications, robotic versus lap, they come out in a meta-analysis like this, fairly comparable. If you look at, however, robotic versus open, there's definitely a trend now that favors robotic over open. That carries out into, if you break them down into minor and major, again, the major, there's definitely an advantage of robotic versus laparoscopic in the major group. And all 3 studies show a benefit there. There seems to be a less of a benefit for the minor liver resections. When you look at blood loss, again, there were studies, and I would say some of the early studies showed higher blood loss in the robotic arm compared to laparoscopy. I would say that's definitely affected the learning curve, and so that cannot be discounted. Be very careful starting out in robotics. When you look at operative times, again, this goes with conventional wisdom that surgeons are learning the robot. They're having to learn how to dock, how to use the instruments. And so operative times overall were longer compared to lap and open, with the exception of when you look at major liver resections in the robotic versus lap arm. And you can see here, in this graph down here, there's one study that pulls the data in favor of robotic, and that's the paper that you can see here from Fruscione in 2019, and that was our paper. That's because our operative time was actually faster than laparoscopy, and the weight of the study, because it's a big study, actually pulled in favor. Length of stay, hospital stay. Again, it's hard when you're talking about institutions in different countries and different continents. Certainly, we're different than centers in Japan or Europe or South America. But overall, there doesn't appear to be a significant benefit of robot versus lap. There is a benefit of robot versus open. And again, to go back to it, there does appear to be a benefit in the major liver resections when comparing robot versus lap. Again, it's the same study, our paper here, which pulled the data in favor of robotics. So overall, I think to summarize this, the robotics allows surgeons to perform complex cases, Whipples, major liver resections in a safe fashion with excellent outcomes. But remember that mature data comes from experienced centers. A surgeon who starts out in robotic liver surgery or pancreas surgery and does their first 25, 30, 50 cases and wants to go publish their data will unfortunately find that their data may not be as good as they would like it to be. Surgical outcomes continue to improve, and I think that with time we'll start to see better downstream oncologic outcomes. And with that, I would say thank you again to the organizing committee, and happy to take any questions during the discussion phase.
Thanks so much, John, for the outstanding lecture. I'm excited with this issue as well. But now I will open to discussion, and firstly, I will invite Dr. Professor Kalil to discuss with us. I'm sure that he has some questions to join us. Thank you so much, Professor.
Thank you, Raphael. Thank you, John, for this excellent talk. I think
You're welcome.
It's a point of to give us more enthusiasm with the subject. We are still in the first moments of robotic surgery and HPB surgery here in Brazil.
Yeah.
And we are very happy to know about your experience. Of course, for distal pancreatectomy, robotic surgery is a very good option, and you emphasize the splenic preservation as one of the advantages of robotic surgery in comparison of laparoscopic surgery. But when we talk about Whipple procedure, you say something that is I would like to understand better, that the surgeon must dominate this operation first. What means this? The surgeon dominate the robotic or dominate before in open and laparoscopic surgery?
Did I say dominate? I'm not sure that I used that verbiage. Is it in my presentation? Maybe the translation was wrong. I think perhaps what maybe the translation was, I think the surgeon, it's really important for people that are considering doing a robotic Whipple or a robotic hepatectomy to really know that operation and know it very well open. And that is so they can anticipate problems or difficult areas. I think it's pretty safe to say there's not many people in the world doing laparoscopic Whipples. So the standard, I think, is to know that operation open and then add in the robotics and master the skills of robotics before you just start doing robotic Whipples. I think that's why it's important to have those different skills, open and robotics, and put them together. Then maybe that's what I meant by dominate.
Okay, understand.
Yeah.
And of course, you showed us the anastomosis was more safe in robotic than in laparoscopic, and I agree completely. The lymphadenectomy, it's a great advantage of robotic. But I would like to hear from you about the volume, the number of the surgeries, and the learning curve in the Whipple procedure, because this was something that it's very important in the open era. And now I would like to hear for someone with a great experience in Whipple procedures.
Sure. Well, I mean, I think the best data that we have specifically for robotic Whipple learning curves comes from the University of Pittsburgh, and they showed something very interesting, that the two surgeons who started the technique there, their learning curve appeared to be around 80 cases, 80 robotic Whipples, which many surgeons, it would take them, 10 years to achieve that, which is probably insurmountable. Fortunately for the next generation, their fellow and a resident that they trained, the learning curve dropped from 80 to 60 to maybe 40 Whipples. Now, so in the United States, people go to meetings, everybody's talking about the learning curve being maybe 40 robotic Whipples. But remember, that was done at an institution that had mastered the procedure, that had a annual volume of Whipples over 100 Whipples per year, had 3 or 4 surgeons who were very skilled at sort of finishing an operation once they got into trouble. So I think it's very dangerous to say, for a low volume surgeon out in a smaller hospital, they may be in a learning curve for years. I mean, 5-10 years. I would imagine that the learning curve is a minimum of 40 Whipples. So I think we really need to be conscientious about who's going to be doing these robotic Whipples. I don't think it's appropriate for someone who is a low volume surgeon, maybe does 5 to 10 Whipples per year. They probably should not be considering to do this operation. I think they should do their Whipples open and get through things safely for the patient's sake. And this really should be an operation that's done at high volume centers. And I don't know how to define that, but I would say it's not 5 Whipples per year.
Yeah.
Does that make sense?
And finally, John, about liver resections.
Yeah.
You showed us some data about major liver robotic resections. And we observed in laparoscopic resections that major resections are easier to do than some resections, non-anatomical resections. That is the main indication of liver resection for metastasis. What is your opinion about this? And it's safe to do in the robotic curve, in the robotic way?
That is robotic Whipple, robotic major hepatectomies?
Robotic major hepatectomies, yeah. And non-anatomical resections with the use of robots.
Yeah. So I'll take them in parts. I mean, when I started in that presentation, I thought the strong part of the robot was the dissection, the hilar dissection, doing things that we do open anatomically, inflow control, outflow control. And really the weak part of the robot was the parenchymal transection. Still is. I think still a lot of people struggle with that. So yeah, I mean, for me, a right hepatectomy and a left hepatectomy are pretty straightforward operations. I mean, I have that operation down pretty pat. It's much harder to do something that is somewhat non-anatomic, where you don't necessarily take the inflow, let's say like a posterior segment 7 or a central hepatectomy, because those really are heavily dependent on the parenchymal transection, and they're doable with the robot for sure, but they're maybe sometimes not quite as as evident that you're getting a benefit from doing the robot. Now, I think that's going to change over time. I think that there's new tools always coming out. I know all of the different companies are interested in getting better tools in our hands to do liver parenchymal transection. So I suspect in 2 or 3 years, we'll be having a little bit different discussion. That we'll be much happier with the approach. But you're right. I think the benefit for me very early on was the hilar dissection. It really made a lot of sense.
I agree completely. I have some cases of hepatectomy, and the hilar dissection is especially a great benefit if we compare with laparoscopy.
Yeah.
It's very, very good. We are very enthusiastic with the possibility to do in living donors, because we have a program with for living donors, and I think it's. I feel more safe to do the hilar dissection robot than in laparoscopy.
Yeah, absolutely. I totally agree with that. Thank you very much for the questions.
Thank you.
Yeah.
A final question about the residents. What is the development for a program of HPB robotic surgery for residents? Because we have a lot of residents probably in the audience.
Sure, of course. Well, I think it takes generations to really adopt this. Like 25 years ago, when I was a resident learning laparoscopic procedures in 1995 to 2000, I did my residency. I had attendings who couldn't operate laparoscopically. So I had already, you had some attendings that were through their laparoscopic learning curve. You had some attendings who would never get through that learning curve, and some who were struggling. And as a resident, you had to figure out who knew how to do what. I think we're in that situation again. I think that clearly there are surgeons, attending surgeons, who are able to and have mastered these operations robotically and can allow the residents and fellows to then go through their learning curve. It's almost impossible if you have an attending surgeon, a faculty surgeon, who doesn't know what they're doing on a robot or hasn't gotten through their learning curve, to allow a resident or fellow to then do part of the operation. I mean, because it's not doable. So the job is, I think our job is to get the attendings through that learning curve as quickly as possible, as safely as possible, so that we can get back to the job, which is really important, which is training the next generation. And I would argue that robot allows me to do that in a much easier fashion, because all I have to do is push a button and I transfer the controls to the fellow or the resident who's sitting next to me on the other console. With the of course, we are talking about dual console. So I think that's really a critical learning platform to transfer, teaching skills and technique.
Thank you. Curiosity, how is the percentage of the HPB surgeries in your hospital comparing to other indications of surgery, robotic surgery?
So in my practice, my personal practice, I would say about 80% of my practice is robotics now, but that's not standard. I would say that other surgeons are still in their learning curve, and then of course I have partners who don't do robotics and they do laparoscopy. Mm-hmm. So that's a whole different discussion we could have about, I never did a laparoscopic Whipple. So my partners who do laparoscopy don't do laparoscopic Whipples. So it limits the percentage of your practice that you do MIS. And so robotics allowed me to do things and do a lot more things, and not just Whipples, but things like, ampulectomies and bile duct reconstructions and Pusteaux and all of the things that I couldn't imagine doing laparoscopically. So that's the truth. It's hard to articulate that with data, but I certainly have some interesting data to share on that. But yeah, my practice is about 80% robotic.
Okay. Yeah. Thank you so much. I learned a lot tonight.
Absolutely.
Thank you.
It's my pleasure and my honor, of course.
Yeah, well, I appreciate also the discussion because, that's really interesting. I was thinking about many aspects of my pathway as well. When I was resident, I was just discussing it last week about the same issue that that time my staff started to do laparoscopic. So if in the beginning you were really upset, oh, that's my time, I want to learn, and so you have to change your mind. But what I did, I realized faster that would be really necessary to learn more than go to the conventional way that I would improve anyway doing my practice, especially regarding the access that I would have to technology. So I changed my mind. That's the main advice, Professor Kalil, that I think that's interesting to the new generation, because today what I saw was soon as I started to do the robotics again, and now it's another different way because I started to do it not in my training. So later, what I realized that the residents were upset as the most of us used to be at that big in our time. And but the idea that I share with them that you have to think where you want to go, not exactly where you are right now. So that's an exciting time for residents also, because today we realize new generations that have some set of skills for laparoscopy, but they don't have a lot of skills sometimes for open surgery. And I do believe that soon, maybe 10 years, we will realize it the same difference from robots and open surgery and robots, or even laparoscopic approach. So that I think that's really interesting, the issue, and keep your mind open to the new technology and make you go further. That's my true impression about it. And I saw John discussing about it many times, so I always appreciated this kind of discussion. That's why we invited him to discuss about that and share certain knowledge with us. Let me see if I have some. I have many questions, especially because I was concerned about when we looked at the technology and also the papers. I was thinking about the methodology, John. If the propensity score matching will be strong enough to avoid the selection bias, because we see better overall survival in patients going to robot, but perhaps that's the cases that are more standard or easier. Yeah. So this is the first point. Yeah. In the second point that I would ask you, what are you thinking about vascular resections in robot? When you do it, up to condition, you do it if it's lateral, you do it if it's terminal resection. So there are two main questions that I have. Thank you.
Okay, sure. Well, let's take those one at a time. I'm not sure that we'll ever have in the United States a randomized study comparing robotic and open Whipples. I don't think it'll ever happen. And I can tell you that because we tried to do it together with the group at Johns Hopkins. And the problem was that none of my patients wanted to be randomized to possibly an open arm. Gotcha. What it is. And so once you get good enough, the patients aren't going to want to be randomized. The second part of that is there is at our center, there are 4 hepatobiliary surgeons, and we do about 120 Whipples per year. 2 of my partners do no robotics, so they do all of their Whipples open. They do not send me their easy cases, and that's because of the compensation. We're all paid based on what we produce. So we're all basically four, even though we're in the same academic division, we might as well be four private surgeons. Okay. So there's absolutely no, there's no selection bias amongst the surgeons. Okay. Now I select, of course, so my open cases are harder cases. There's no doubt. Those are crazy cases, the cases that I do open. But my standard cases are the same as my partner's standard cases because they don't send those patients to me. So it's not randomized, but there's also no, it's not like at the University of Pittsburgh, there is definitely a group. Hey, we're going to put all standard Whipples in this robot, and then the tough ones will be open. But at our institution, that doesn't happen. And so that's why I would tell you that our paper in many centers like this, our paper, there is not that effect, that selection bias effect. And so matching those patients, when you match them for age, sex, BMI, comorbidities, tumor staging size, T stage, and all that stuff, you're comparing apples and apples. Those truly are comparative groups. And I think that's going to be the best you're going to get in North America. Well, I would say United States. It might be able to do something in Canada. You can only accomplish something like that in a place like Europe, Netherlands, somewhere like that, where patients are going to be randomized. It's not going to happen in the U.S. So we're going to have to go with what we've got, and I think that's going to be adequate in terms of the data. The second part was vascular sections.
Yeah.
I've done a couple. I think you have to be incredibly careful with these. We already know that the data for doing a Whipple with a segmental vascular resection, even in a center like ours, the mortality is tripled. It goes from about 3% to about 10% more. And this is perioperative mortality. And that's at a place where I work. I mean, we're really good at what we do, but the mortality is 3 times because all it takes is the littlest thing to go wrong. And so if I'm doing a Whipple with a vein resection, and I know I'm going to do a segmental, like an interposition graft, those are done. I do those open because I just don't have the headache. I just don't have the time for that. Could I do it? I've done it. Should it be done? I think you got to be really, really beyond, your learning curve. Somebody who's done like 500 Whipples and in their career and done 50 to 100 vascular resections, I think you have to be really out there to do these kind of things. And it's because of that. There's so many things. And as surgeons, we are obligated to perform the safest operation we can for these patients. And I can honestly say that I can do a robotic Whipple as safe as I can do it open. I cannot say the same for doing a vascular resection. Okay, so I think that's a whole different ball game. But you'll see stuff at me. I mean, you'll go to meetings and you'll see all kinds of things being done. But the question is, how many patients died in that group before they accomplished that? I think we have to be as a group of surgeons, we're doing high risk operations. We're not doing colon resections and hernias. These are things that carry with them real mortality. So I think that's important to remember.
Yeah, I mean, I know a little bit how you're thinking about that. My question wasn't naive. Yeah. In fact, the idea is to good send some message about that, because when for our audience, we saw a lecture outstanding like yours and your practice. You think that no limits for minimally invasive surgery resection. And also another comment that was really good from Professor Kalil was about the living donor. So, it's possible. We know that's possible. However, it's a long training, a huge responsibility to do it. And And that's why I'm always I ask you about the vascular resection, exactly because, you know, it's a due, more complicated deal than to do the Whipple, standard Whipple when you start to do and do the resection and everything. So I think that's really a point that should be done. And the one comment for both of you that I really think that's interesting, that's about the how to cut the parenchyma. And I do agree that's, you know, that's the most variable technique that I saw in liver surgery, regardless we are talking about open, laparoscopic or robotic, because it seems to me that depends a lot about the school when you're training, but also about the hospital and your facilities that you have, like Cavitron or whatever. So that's interesting. But I think it's possible, Professor Kalil, to do minor resections. I've been doing some. I think that's good. A good indication, exactly because you can use the articulator. What I will have to keep in mind that you're not doing it like a Cavitron fashion. You're doing like a bipolar and monopolar. So if you do like that, or perhaps you can go and use some advanced device like harmonic or the bipolar that John showed us, the advantage that's articulated. But at the end of the day, the idea that the surgeon do whatever he has more experience doing to cut the parenchyma and what they have over there. That's my impression about that. Okay. Any other comments, Professor Kalil?
No. Just thanks, John, for his lecture, and as I said, I learned a lot, and I am more enthusiastic to continue with robotic surgery. I think it's good to hear from someone with good experience to don't have your feelings in the beginning, to go slowly.
Yeah. Well, it's taken a long time. I will tell you, it's been a long road, but I don't think everyone needs to take that long. I think we just have to do it very carefully and keep pushing forward. So it's definitely a good thing.
Okay.
Thank you.
So,
guys.
John, in the name of the Brazilian College of Surgeons, I would like to thank you so much for your time and consideration with our college. For us, it's a privilege to have you here with this outstanding lecture and sharing such knowledge. We really appreciate it. Okay. Thank you so much. Thank you guys for participating. I'm pretty sure that everybody like it. Okay.
Thank you. So thank you both very much, Rafa and Dr. Kalil. Thank you very much. And thanks again for the invitation. It's my pleasure and my honor. Hope to see you again soon.
I hope so.
Okay.
Bye, guys.